Lecturer of the Crown and Bridge Division, Department of Conservative Dentistry, Prince of Songkhla University. Also, he is the Clinical and Course Director for undergraduate and postgraduate programs in prosthodontics.
Dr. Shashwin received his Doctor of Dental Surgery degree from Prince of Songkhla University and completed both Certificate of Advanced Graduate Study and Doctor of Science in Prosthodontics at Boston University.
His lecture today is titled Digital Foundations of Smile Design, Pathways to Predictable Aesthetic Outcomes. Please warmly welcome Associate Professor Dr. Shashwin Angura Wasapon with a round of applause.
Hello, good afternoon everyone. Thanks for coming. The picture inside here is look like me like 10 years ago, not today. Thank you for everybody to make me look a lot younger. Okay, today we're going to talk about digital smile design. Right now, we have a lot of technology to utilize to help our case make it a lot easier. In the past, when we want to do something, everything has to be collected in the paper. Everything is most likely rely on the skill and experience of the operator. But now, because of the coming of technology, it can change dramatically the way we practice, the way we see, the way we treat, and the way we communicate with the patient. In a traditional way, when you want to restore the teeth for the patient, if you didn't have much experience, if you like the beginner, most of the time when you see the case like this, you're thinking that, okay, how we put the teeth together, how we close the space, how we do make it occluded to each other. But in fact, in reality, the tooth of the patient is just a part of their face. I would say that a teeth of the patient, when we show it, like intraoral photographer, show it. It's like a picture when you're drawing, when you're taking a picture. But the lip of the patient is like the frame of the picture. Without the right position in the frame, even to have a really nice teeth, it could be a little bit too low in comparison with the lower lip, or it could be a little bit too high to export too much of the lower teeth. It's very hard to make it right at the first time for the patient, how to put it in the correct place position. Moreover, when you are working with the case with a picture, if you did not correct properly information, when you see a picture like this and you send it to the lab, ask the lab to do the lab work. Okay, this patient coming in, she wants to fix her smile, she wants to make her 6 or 8 and 20. At the beginning, you will think, oh, this case is simple. So smile line is very close to what we want, to what we need. It may be just at the quadrant 1. Here, electoral incisor is just a little bit almost edge to edge. You may need to make it rotated over by, you correct the shape, may correct a little bit of proportion. So we just decide according to the information we have that we send it to the lab. However, if you take a look closely in the patient, in fact, her teeth occlusal plane is canting. Without the technology with the digital, without the photographer, without the proper the examination, it could be a lot easy for the dentist and for the lab that made the canting restoration for the patient. So, the principle of smile design is not only looking at the teeth. We have to look at the big picture. Not only the teeth, but also the frame, the lips, and the face of the patient. Then, in order to correct all of this information, you have to run examination, go through like dental or labial analysis, like tooth exposure at rest, smile line, lip mobility, incisor edge, smile width, labial corridor, interincisor line and midline, occlusal plane and commissural line. This is for just extraoral and the teeth parameter that relate together. But if you open the patient now, you take a look closely, you have around 14 parameters you have to correct. Then at least without the digital technology, you need to correct at least 21 parameters to be registered into your information and make it right, make it correct. So, in order to input all of the parameters, everything together to create a work look like this, you need not only experience, you need the well train of your hand in order to craft a smile for your patient. So you maybe have to be a little bit of like artistic. You need a very well experience in order to create a good restoration for your patient. And then when it relies on the operator, everything is sometimes, I would say, it is unpredictable. It depends on your dentist. If your patient is lucky, you find a good dentist, you may get a good restoration. But if you are not lucky enough, you could got a good dentist, but you got the technician who not well trained, the outcome may be a little bit unexpected. So, with the coming of the technology, we don't need to rely on operator, don't need to rely on lab that much anymore. We use technology to make our life a lot easier. With the digital technology, you can use intraoral scanner to capture the 3D model of your patient teeth. We can use extraoral photography to collect how the patient smile, how they speak, how they talk. With a couple series of extra photography with the intraoral scanner, you can collect all of the information you need. So in comparison with traditional and digital, digital way is you will feel like that you have your patient right next to you at the unit, even the patient is going home already. Something with some information that you may think you missed it during you run oral examination, you can coming back and take a look again. So it makes our workflow easier. Then we come up with the first generation, is 2D digital smile design. For the 2D digital smile design, no sound. But it's okay. It's okay. We incorporated extraoral photography and we merge it with the intraoral photography, like smile and open your mouth and close your mouth. This way of digital smile design, the 2D smile design, you superimpose two pictures. And after you suppose two pictures, you can create design for your patient. Either smile line, tooth height, tooth width, tooth proportion. However, if you notice that when you're working at the 2D smile design like this, it's same like you just do a Photoshop for your patient. Everything you can create with the Photoshop. You can put anything into a picture. But in fact, so many times when you try to implement what you design from the picture into the patient mouth, sometimes it's not possible due to like some of it may be a little bit labio version, sometimes it may be a little bit of rotation. So veneer may not be an option for many cases. It may end up to be a crown, or either you need to go for the orthodontic treatment first before you go for treatment. Plus, after you got this one, you just got a 2D picture like this to show to your patient. You might sell the case, patient, oh, it looks nice, it looks great. But in reality, when you're working, it's not possible to make it in the real life. Then you may have a new trouble later on after that. Patient may say that this is not we are talking about at the beginning. Plus, because it's just a 2D picture, it's not related, it's not working together with a 3D information like an intraoral scanner model like this. When the technician want to create any restoration for real, for the mock-up, they will put a 2D picture that we designed to show the patient together adjacent to the 3D model like this. And they try to create restoration by mimicking. They just try to make the teeth as close as possible. They try to copy it, but they did not relate directly together. In some case, if you want to perform like aesthetic crown lengthening, you need information like how long of the root it is, how many bones do we need to cut. You need to use an X-ray to superimpose it manually like this, which is not convenient and is not precise. You just got only tentative document. So we realize that the problem is the 2D is not effect the real life condition so many times. Then the new evolution is we incorporate this is the new version. We evolution from the 2D photo overlay into the 3D anatomical integration. With new technology and with the help of the AI, we can merge the 2D picture, the 2D design into the 3D model of the intraoral scanner. So, when we decide that everything if we put together in the same place in the software, you can do the like 2D smile design, and at the same time you can see what's going to happen in the real life of the patient. You can see in every direction, detail optical plane, lateral view, optical view, labial view. Let me show you some here like this. This is what happened when you do only the 2D smile design, and you did not realize that, in fact, sometimes it's not possible. Would it be better if we do a smile design and it directly link it to the final restoration? This is the new version of the smile design. When you move your teeth, restoration, you make it, adjust it to make it possible or feasible to match to the reality, and you see the final outcome immediately in the 2D smile design. This is the power of the new software. Not only that, you can create the final restoration, you can create, export it into, make it a mock-up, to make the final restoration to show to the patient and to work it later on after that. That means everything is incorporated together in one software, and you can export it, you can use it. And then you can export it. After you got your final design in the model, you can either use it conventional way by 3D printing model, and you go for the PATI mock-up, go to the patient mouth, or you can use this model to work later on for the digital processing. The advantage of digital smile design is like enable patient communication. Patients see together. If you have enough time to talk and sit together to see that to the patient, this is what I think maybe look good for you. However, what we think is good for the patient, it might not suitable for the patient personality, might not perfect for what he or she want to achieve. With this software, we sit together, we can talk, we can communicate, and we can adjust, we can alter, and we can also tailor-make for case by case. Don't need to be like something pop out from the catalog. And sometimes, if there is some limitation, you can show it to the patient right away that this case we can do it, but you will have to sacrifice something. If you think it too much, you may need to go for the orthodontic option first, or you may need to do, okay, ortho is too much, you're willing to go for RCT and intentional for the crown. It depends on the case. And it's improve the way we communicate to the lab too. Because everything is like you see it, and you talk into the lab. You can incorporate into the other people. However, in the contrast, in the dark side of the technology, they say like, if anything happened to the technology, let's say that's the beginning of this afternoon session, computer just doesn't work. For whatever reason, the internet is going down, the server is going down. If you don't have the manual skill as your backup, you may be in trouble. So there is a chance of addicting to the technology, overuse it too much. And also for a lot of the staff who work conventional way for the rest of his life, they work in this way. When you want to learn something new, is have a lot of learning curve. It's not only you have to learn how to use the technology, you need to learn how to understand the basic about the computer, basic about the 3D file, STL, PLY, how to merge and how to manipulate it. So they may have not easy to adapt into the new world. After you got your model, you can end up it just like conventional way, you print out 3D printing. After you 3D printing out your model, you use work conventional way with the putty. Or either you use the STL file that you got from the design this, you can create a digital guided preparation. For the conventional way, because we use a putty, the putty made it as a mold, as an external surface form of the final restoration. And put the putty into the patient mouth, most of the time you feel that. How do I know that? Sit properly. How do I know that it's not like wobble? Because putty is not like a solid. It's still like some flexibility. If you put it a little bit too harsh, put it too much, or the lip of the patient push into the putty, sometimes it distorts. So it is kind of unreliable. It's just like some index for you. But for the digital, when you use something is very solid, like this, like acrylic resin, you use like the composite. So it's solid. When you put it, it's very stable. In the same way, you design the guide for the implant, like implant guided surgery. Just after you put it in place, everything is not moved. So you can see it easier and you have more reliable. Plus with the technology, you can see it immediately. If any area of the tooth, you need to alter before you make the index for the patient. The color will show you that before you put anything to the patient, sticking it out, you have to guide it and shaping it out. There is many types of the preparation guide. There's so many designs. Some of the design, they try to make it like, this called stacking guide. They have one piece of the guide as a base. And you have like the overlay, put it on top for the labial, for the incisor reduction, to see at the mid level, to see at the incisor level. And then at the end, you can measuring the thickness by probe. This one design has been proposed. And another design, they try to do it separating guide. They make a separating guide. This one go even further. They make a slot in the guide. So you can put your burr into each direction. It's the same way you use the computer-guided surgery for the implant. So the burr direction will be manipulated by the slot that has been made. But this design has some disadvantage. For example, you need a specific burr that's long enough to go through the guide and to go to your teeth. And plus, sometimes when you do preparation, it's not enough water coolant. Because the guide, this one will block water from your handpiece. So right now there is like not gold standard dies for the preparation yet, but so many proposed design, and this is another design for the guided preparation. They made it like this, and they made a hole to the specific burr. This one is an auto stop because the burr will just put in go to at the end of the hole. And you got like a dipping on the surface of the tooth, and you guiding your teeth. So when you use a digital guide, it will utilize that technology, make it more predictable. You reduce your tooth structure less. You have more control, and you can standardize. You don't need to rely on a lot of skill of the operator that much. Limitation. The workflow is quite complexity. You need a lot of the lab work, you need a lot of equipment, and you also need your technician to understand, to truly understand how to manipulate the 3D file. Sometimes because of a lot of guide, there is a lot of acrylic in front of you, maybe the limit of some of visibility. You may need to adjust to learn, to practice yourself. And initial investment is a lot. If you already have owned your intraoral scanner and everything, that's fine. If you don't have intraoral scanner before, that is a quite deep investment. Okay, and this is a case, for example, to show that how we do it at the PSU, how we use it to digitalize, to work with patients. Let me invite some of my guest speakers, my student, Dr. Varaya, to talk about it in this case.
Thank you. Oh, quite a big stage. So the patient was referred from the orthodontic department. Actually, the very first sentence that she said to me is, "I don't like my smile. It looks like a monkey." You see, she explained that whenever she smiles, her gum shows up a lot. And then she asked, "Can you make my smile better? Can you get rid of my gummy smile?" As you can see from the picture, the gummy smile in this case is mainly caused by the short clinical crown. And when we compare with her raised position, we can also see that there is some lip hypermobility going on there. So let's take a look at the potential causes of the excessive gingival display. We can group it up into 4 main categories: lip, dental, skeletal, and gingival factors. In this case, the patient didn't have any gingival hyperplasia, and she had already undergone the orthodontic surgery. So basically that ruled out the skeletal and the gingival causes. There were just a cause left, which were the short clinical crown, which we plan to manage with the crown lengthening, and the lip hypermobility, which we plan to treat with the botulinum toxin injection. I started planning with a digital smile design. So checking the tooth proportion, confirming with the lower lip line, just like the way he taught me. Thank you. And look at the whole picture. But at that time, the 3D digital smile design wasn't officially available yet. So I had to work with the 2D data mostly. To be honest, there was a big struggle. For example, when fabricating the color lengthening guide, I had to manually superimpose the PA X-ray film and the photography. Like that. But once I finished, the guide became a great communication between me, the periodontist, and the lab technician, and of course, our patient. After everyone agreed on the plan, we fabricate the color lengthening guide. The periodontist can place the guide in the working area, then perform the surgery exactly as planned. Here's the 2-week follow-up. Then compare before and after. And here's a compare 2 weeks and 3 months after the surgery. As I mentioned earlier, the second issue was the lip hypermobility. The upper lip can move excessively due to the overactive audit elevator muscle. To address this, we use the botulinum toxin injection just to temporarily reduce the muscle activity during the facial expression. Here's the list of the FDA-approved botulinum toxin. You can see the detail at the table. The target muscle were the levator, labii, superior, and lignacide, both left and right side. You can locate them just like use your finger like this and place it simply next to your nose. Yes, like that. So after the long journey, and finally, here's the outcome after both the color lengthening and the botulinum toxin injection. Here, you can see the amount of gingival display was significantly reduced, and the patient is very happy with her new smile. Well, the next plan is our main job, the restoration. Even the patient has undergone the color lengthening surgery, you can see from the picture, the zenith and the gingival margin is still some parts are uneven. There are some creeping parts that you can see on the screen. Do you notice some creeping? We will see more about that, what the 3D can do on the planning veneer. Luckily, now we have the 3D digital smile design available. This software can integrate the data, the model, the CT file, and we can use it to do the digital wax up. And we can just shoot our little finger like this to drag it and see it every part of it. Well, at this point, if you guys curious about the 3D digital smile design, I would like to hand the stage back to my lovely mentor, Dr. Shashwin, to explain more about this. Thank you.
With the data, we have it right now, information. We notice that the tooth of the patient have some, the gingival of the patient have some creeping. We notice that we need to do compensating during the final restoration. So we do digital smile design in 3D. We incorporate every data together. With this software, you just import the picture, extraoral photography. You import data of the intraoral scanner, and you design. In the beginning, you start the same way as you do a 2D smile design. Put the right shape, put the right proportion for your patient. With the AI, it will not only select a tooth shape for your patient, but it can also make it adjust suitable for the space your patient have. You can make the point that where is your high upper papilla, you can alter it where it's supposed to be, such as incisor edge position, smile width, smile height. In this case, at the beginning, after I saw that, oh my God, patient asked just want 6 and 3 teeth, it's going to be a lot better if he do for 8 and 3 teeth. Because with his smile, we can see clearly that on the premolar is still visible. But due to the financial limitation, they can just go for 6. After we notice the information, everything, we do it. Let's say we can do a tooth setup. We arrange the teeth in the model. If you don't like it, let's say it's a little bit too can, you want it a little bit too distalized, too mesialized, too a little bit too big, too small, and you can adjust it like this. Basically, you just do a tooth setup in the software and you see the final result in the patient mouth. Let's say in this case, I found out that on the right side of the patient, the oxal plane incisor edge is a little bit too short in comparison with on the quadrant 2. So I increased the length of the teeth a little bit. I decided to cut the incisor edge of the lateral and the canine. After everything has been done in the software, you can see the final result. You can see that where we have to cut the teeth more, where we need to add it. And then we can check to verify. If you think that only the frontal view is not enough, with the right now software, you can see on the side of the patient. The software can match, to merge what we just designed, this one to the lateral side of the patient. And after it matching together, it can generate the final outcome for your patient. See, with this you will notice immediately. The teeth is a little bit too inward or too outward, or it's about right at the lower lip. Because it's a 3D dimension, you can see in every direction. And not only that, the right now technology is not only create the blueprint for your final restoration, they can generate it, how it's going to happen in the patient mouth. This one is computer generated from a 2D picture, but they can make it look like patient is speaking. This is AI generated speaking of the patient. So we can see roughly how it's going to happen when patient talk, when patient smile. After we got the final, we got the shape of everything in the model like this, as we wish. We have 2 options. First, you just print out the model from the final restoration like this and go it with the conventional way as you did it before by making a putty. Or you have the easier second option, you go into a digital guide. Let you guess this case. which direction we are going to heading. The conventional or digital guide become all along this way, so we decided to go for the digital guided. We use this information that we got it from the software, we export it to make it like a 3D model, and with the ExoCAD software, we can manipulate, create the digital guide. With this guide, you can see that where we want to go to the depth cut, how much we want to go, how much we want to grinding the teeth out. And we also printing the model for verify and for as backup too. Not only the print guide, we also have occlusal rejection guide. This type of guide gives you a lot easier and more convenience because you can, let's say you want to guiding for 1 millimeter, you can cut back in the software 1 millimeter in the software right before you go into the patient mouth. So what's going to happen in the patient mouth is you put the guide in and you use your burr to guide the teeth to exactly the same level of the guide that you planned. No need to be like guesswork. Just go exactly as the guide has been designed. And then for the labial, we can use a depth guide to go to the labial reduction because we have a slot. And each slot, we know that exactly how thick it is of the material it is. In this case, we use a probe to utilize to help that because we know that this one is around 3 millimeter thickness. We compensate with the burr side diameter and we go to the depth cut, go through it, and use the probe to verify. This way is a lot more precise in comparison with the cutting because we can see all the 3 dimensions of every area, this incisal edge, within and the middle, and the cervical. And this is the final result of your preparation. You will see that we see at the beginning, the gingiva has been creeping before we do preparation. So we compensate a little bit before we make the final impression. And because we go for the digital, we go with the digital impression. We use a 3D scan to digitalize all the information and we send it all to the lab. And this is the information sent to the lab. And then we communicate with the lab. We ask them to design the final restoration. So when the lab sending it back, we can superimpose to the model preparation. With this superimpose, you will check your work a lot easier. You will see that each area is enough thickness or not. You want to increase or you want to decrease. You can also see the cross-section of the model. Oops, sorry. You can also see the cross-section of the model in each area. Because sometimes when you want to increase the thickness of your restoration a little bit, because the color of your sunshade of your abutment, to increase the thickness of the restoration. Or sometimes you do not notice that patient one is natural, it look like a natural smile. The color of the abutment is not that thick. So you can manipulate the thickness of the restoration a little bit because you see this. And if just in case in this area or in any particular area you notice that this one is not enough preparation for whatever reason, you can ask patient coming back to guiding a little more for the future, or we go on with just like file restoration and we do just one later on. It depends on your case. But you see right before you got your restoration. And after you approve the design, approve the shape of the restoration, you got the lab work back from the lab. And this is when we try in the restoration. Okay, this is the final result. This is the first time when patient coming to us, and it's at the end after we do just 6 veneer for a patient. Right now, patient she's very, very happy. She said that after she going back home, everyone asked her what did she do, what's happening. Most of people notice that she's looking better, but she doesn't know it's because of the teeth. And this is the video, I just want to show you that. This on the right side here is the computer generated, and on the other side, this one is from the real. I recorded with my phone after he got the final restoration. You will see that AI generated it's not that accurate as the real one, because this patient, she has deep hypermobility. But however, even it's not like exactly as it's supposed to be in the real life, but it's close enough for the patient. This one, I try to talk with her, I try to make her smile, I try to make her laugh. So when she's laughing, most of the time, you expose your gum as much as possible when you're laughing. There's a maximum that's exposed. So that means in the worst case scenario, even she's laughing unintentionally, it's still not looking too bad. But when she smile, intention, everything is good. And this is one I superimposed my scan of the final restoration to my preparation. Because of the guided preparation, you can control the thickness of the restoration. It's very close to what I want, around 0.8 millimeter to 1 millimeter on the labial side. So after this preparation, all of the restoration is sit on an enamel, except the cervical, of course. And I superimpose again my final restoration with the teeth before the preparation. And this is another picture to comparison before and after. See, the way we restore the patient, we restore the smile, not only the smile, but the confidence. When we put something that makes patient feel more confident, she will look beauty from the inside out. She talk more confidently, she very happier, and she have more motivation. She pursue for more aesthetic in some area. After this, she asked me, okay doctor, at the beginning I think lower teeth, I will let it like that. But after that, I think, can you do the lower for me? He started going for something else. He want to go further. And this is a story, the whole series of the case. For the beginning, before orthodontic treatment. After orthodontic treatment and orthodontic surgery, and then we got aesthetic lengthening and Botox. And the final, we do a linear restoration. And this is right now how the patient smiles. The patient very cooperative. You see, even the gum is very healthy. It's very nice. I mean, she very do cleaning on your teeth. And at the end, don't forget that every restoration needs for maintenance, needs something to protect. I would tell to my patient all the time that this is your investment. You need to protect it. You need to protect your investment. So better to have some night guard or occlusal guard to make sure that you're not guiding your teeth during the night time. So I use the intraoral scanner. I do a CR record with the Luciagic and the 3 hours, and then fabricated CAD/CAM splint. So to summarize, technology, it could enhance your patient communication, and you can co-design with them at the beginning. So when you co-design with them at the beginning, it increase rates of acceptance. Plus, this one is calling that prosthodontic driven. You know exactly what we are going to see at the end. We see the final result from the beginning. This is what we want. So we and the patient have the same goal. This is our goal. Are you agree with me? If not, what do you want to share? If design of the teeth reflects on what your expectation, reflect your personality, or you want it a little bit more more aggressive, because sometimes patients have some different personal preference. Some want it a little bit longer, some a little bit softer, some want it more softy. It depends on the patient. And with the workflow efficiency, everything is almost everything is work in the computer. So you don't have to sit in your clinic all the time. You can work on your laptop, even before going home. You can communicate with your team in the software. Everybody don't have to sit together at the same place, but you see the same information together, and we can talk, communicate it into in the chat. We just need, let's say that, okay, tomorrow at 1 o'clock, everybody in the meeting room, and then we looking at the case together. Okay, moreover that this one is good for the clinic, because sometimes this kind of treatment is patient pay a lot and have a lot of expectation. So this one is some kind of medical record, like for the consent, for the legal protection. This is what you were talking with us. This is what you sign for approval at the beginning. If we have to redone, if we have to redo, the cost of treatment is on your own behalf, not our behalf. Because you agree, you see it at the beginning. So it will be a lot useful. Okay, before at the end, we have to thank to Dr. Tipawat. Dr. Tipawat is a doctor in our faculty who helped us this patient to do the inject for the botulinum toxin for this patient. And another one is Dr. Pakron. He was our student. He is our alumni. Now he works in private practice. He is the one who helped me to fabricate the digital guide. As I told you, this one they need a lot of the learning processing. Not all the lab know how to make it. Not all the lab understand how to manipulate it. I asked at least 3 or 4 dental labs. They said that they could not make it for me, and willing to do it by myself, but our school don't have the ExoCAD yet. So I had to ask him, excuse me, would you like to help me? And he's willing to help me to create all of digital guide for free for the patient. Thanks for both of them. Thank you.
Thank you, Dr. Shashawin, for that wonderful